All right, I'm just going to hop over to Facebook and make sure we are indeed streaming there. And we are. All right, people are already filling in the room, so let's not keep them waiting any longer. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation and Neuroendocrine Cancer Foundation program. My name is Rain Bennett. I am your host this episode. And every episode, I have been working with CCF and now NCF for many, many years, over a decade at this point, creating all kinds of video content, some live Q&A series like what you'll watch today, patient-centric documentaries, treatment-based videos, conference and event videos, all kinds of videos in that decade plus, but all with one singular mission in mind, and that is to spread awareness and education about neuroendocrine tumors. Now, if you are new to this journey, to the NET community, I want to say welcome, or certainly if you're new to the show, appreciate you being here. This community is incredibly strong, incredibly supportive. And so what I would urge you to do if you are new to the show and or the community is to embrace that, embrace them. You'll see people signing on in the comment section telling us where they're signing on from across the world. That's something that we do every week. I encourage you to do the same thing. You might find someone in your space, especially if you're in one of those regions that doesn't necessarily have a specialty center close by, or in another country. Introduce yourself, embrace the community. They will embrace you back. It's something I've had the pleasure of witnessing over that decade plus. And, the value that I see here on the show is very clearly twofold. The information that you'll get from our guests and hopefully answers to some of your question. And also at the same time, the shared experiences and shared stories from within that community. I can't tell you how many guests, how many doctors we've had on the show that tell us that they also get a lot of value from this. They also learn from these programs. That to me speaks volumes to the community, the overall NET community. It's something very, very powerful to witness. Now, in that vein, on that note, I have a little bit of somber news that I regret to share today. Earlier this week, the titan of the NET community, I would say, the founder of CCF back in 1968, Dr. Richard Warner, passed away. He was 97 years old and still serving patients into his 90s. I worked with Dr. Warner for many, many years. I got to know him quite well and his family. I know all of his children. Keith, who has been the CEO of CCF for many years as well. Dr. Warner was not only the founder of CCF and this is my words, but what I would consider the godfather of NETs in many ways. And pardon me if that doesn't land well, but this community that I'm talking about initiated with him and the foundation and all of these great doctors that really got it off the ground. And now I see us passing the torch into this next generation. But Dr. Warner was such an impressive human being. He wasn't just this top doctor in this rare cancer. He was a pilot and an athlete and a world traveler and just an incredibly impressive person. And I will also say, and then we can go ahead and start the show, that I interviewed him many times. I even helped tell his life story, a video that will be featured at his funeral. And he was a very, very stoic, straightforward man that probably made him a really good doctor. And I think once, perhaps twice, my job as a filmmaker is to pull out emotion, right? That's our goal. I saw him get choked up one time in all of the video work that I did with him, and that was when he was discussing his affection for and his dedication to his patients. So when I tell you that this man took it very seriously, his role in this community, he absolutely did. And if you wanted to donate anything in his memory, we'll put this link in the comment section. You can send those donations to ncf.net/Dr.-Warner. Again, we'll put that link in there. Anything that, if you want to, obviously that is not necessarily an ask, but we would direct those to there. So all love to Dr. Warner and his entire family, his children, his grandchildren, and his great-grandchildren. We appreciate everything that you have done for this community. Okay, that said, let's get today's show started. Today, we are excited to welcome back to the show. We've lost count how many times. It's been a few times. Dr. Dan Halperin. Dr. Halperin, how are you?
I'm all right. Thanks, Rain. It's good to be with you.
Absolutely. So, speaking of the NET community, for those that may not be familiar with you and the work that you do, tell us where you work and what is the role that you fill in this community.
Yeah, it's funny. I have to say, even though I have done this a few times, I feel like it's the first time it's really struck me the way that you described the and how much that resonates with my own experience of
Oh,
being
man.
an oncologist here in the past, decade plus of dedication to people who have neuroendocrine tumors. And I really want to echo, both the both my condolences about Dr. Warner to the foundation. He was a giant. You're not alone in feeling that way, or a titan. And also my appreciation for this incredible community of people, and just sort of reinforce how much people gain out of leaning in to the community and learning from everyone else. I certainly have, and I know many others have as well. So I'm a medical oncologist. I've been taking care of folks with neuroendocrine tumors for, like I said, a little more than a decade now. Recently moved to Emory from MD Anderson. I was there for about 12 years, and since I've been here for about 9 months, we focused on program building. So recruiting people who are focused on taking care of people with neuroendocrine tumors and building out our science and clinical trials and clinical enterprise. And then also I have a role sort of more globally in the Department of Hematology and Medical Oncology. So I also am working rather hard on sort of the bigger picture of how we deliver cancer care across our large academic enterprise. And it's really sort of, it's fun to be building two totally different things at once, thinking about the rarest of the rare and the most common, and how we try to take care of everyone and grow and make progress together. So it's an exciting time. It's a busy time. But yeah, that's kind of me in a nutshell. I'm glad to be here.
I wonder, you kind of given us that timestamp of about a decade plus, similar to my association with the NET community. And so, and speaking of these titans that I alluded to earlier, I feel really fortunate because when I came on in like 2011, I got to meet and work with and interview a lot of these names that help shape this community. The Dr. Wolterings and Warner and Dr. Wolin, Dr. Zachs, the Odoricios in Iowa. And what we love to do here on the show, and something that I've seen is, as I mentioned before, this kind of passing of the torch, this new generation, a lot of younger doctors that are taking us forward into the next 10 to 20 years. And so I'm always curious, was there someone in the NET space that you view as your mentor that kind of got you started? Okay, you're nodding your head. So I tend to see that happen a lot, and that excites me to see those connections.
Yeah, no. So I mean, I remember vividly. I was a second year resident in internal medicine, right? So for context, I had graduated medical school 18 months previously. As many of us do, I was going through my existential wanderings, and I landed in Matt Kalke's office at the Dana-Farber at the time. And I distinctly remember we sat down at his table that day with something to work on. He said, look, this is a really rich community of patients who need doctors and science that needs to move forward. And, if you'd like to make a difference, basically come on in, the water's fine. Right. And, it really, and then from there, he really sort of brought me into this notion of sort of how do we, execute science at scale to make progress. And then as I moved into my fellowship, he said, hey, I have this friend, James Yao, who you might have heard of, who had just published Radiant 3 in the New England Journal. And he said, look, give him a call when you get to Houston. I think you'll like spending some time together. And then I worked with James for a dozen years. And so really, thinking about that generation of folks and it's funny. I was doing some teaching with the fellows this past week, and they put up that classic timeline of, we had octreotide, and then
Yep.
we had nothing, 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 and then we have all these, this explosion over the last few years. And to
Totally.
describe to them the notion that, the key intervention, the difference was people like Dr. Yao and Dr. Kulke, who said we can do good science and move things forward by actually believing that we can do real clinical trials and learn things and know them rather than relying entirely on anecdotes. That's what transformed the field in that time frame, and has really made a huge difference in the way that I view the world and take care of folks.
That was inspiring. I appreciate you sharing that. Thank you so much. Well, folks, it's 10 past. The questions are rolling in already, so let's go ahead and get to them. By the way, folks, I know I say this every week, but if you're new here, the best way to ask your questions and formulate them is in small, generic chunks. There's no limit to how many you can ask. If Dr. Halperin needs a little bit more clarification, or if we might ask for that, you can chime back in. If you have a follow-up question, that's all good as well. We'll try to push all the way through to the hour and get to as many questions as we can, but that helps us do our job a little bit better. So speaking of which, first question comes in from Matt. Matt said, I just had my first CT 90 days ago post for PRRT. Scan shows stability, no growth or spread. Doctor says PET scan in September with hopes that we see stability continue for at least a year. This is a very common question. Any advice on what is next? I'm hoping for long-term stability or remission. So a lot of people get in this stage, and I think they might want to take more action, perhaps.
Yeah, it is such a, this is a question we answer in the clinic, I think, every day. I often think of this as, like many other interventions we do, we deliver the treatment just like if you were doing a surgery or a Y90 to the liver or what have you. You deliver the treatment and you get control, and the evidence really does suggest that you get a holiday afterwards. I think the post PRRT is a really interesting space, in part because we now have both the data with concurrent / post PRRT somatostatin analogs in NETTER1 and NETTER2, but then we also have sort of non-concurrent SSA data with COMPETE, and obviously COMPOSE isn't done yet. But the strategy of, do we give SSA with somatostatin analogs, lanreotide, octreotide, with and after PRRT or not, has never been asked directly. And so I think there's a lot of nuance and personalization there, frankly, because the data haven't answered the question. But really, it is not unreasonable, based on the evidence, to expect months and years of control before you have to move on to putting more poison in your body, which I like to think of as a good thing.
Yeah, absolutely. Thanks, Matt. Appreciate your question. Still sticking to PRRT. Next question comes from Shane, one of our most consistent question askers here on the show, who was surprisingly not in attendance last episode, but we won't mention that. Shane says, can new tumors or growth appear? I muted my mic. Apologies. That's what I get, Shane, for messing with you. Can new tumors or growth appear after 2 cycles of PRRT, but stabilize after all 4 treatments are completed, since it takes some time for the full effect?
So this might tell you more about me than it does about cancer, but I've learned over the years that I don't believe in 100% or 0% after you've done things thousands and thousands of times. If
Fair
someone
point.
says, can it? The answer is probably yes. More or less common, I think, is a more helpful framework. Can it happen? I imagine it can. You could envision scenarios in which you only get enough uptake when it gets to a certain amount of size or density or something. I would say, is that a common thing I've seen? It's not a common thing I've seen. That doesn't mean that it never happens. It just means it's probably not the most common.
Copy that. Next question from Lynn. In 2018, had primary in the tail of pancreas removed. Since then, multiple treatments and therapies. The latest was PRRT and SBRT in the fall of 24. Doc's shocked as tumors are gone. That's good news. I have a great appetite and eat a lot all the time. However, I just can't gain weight. I'm now down 35 pounds. As of now, not losing weight, but I still can't gain weight. So the question is there something to take or to do for possible malabsorption?
Yeah, it's a really good question, especially in folks whose pancreases have, suffered from steel and radiation, and often our medical therapies. Also, I don't know what we have against the normal pancreas, but we really tend to beat up on it a lot in our field. Um, so, what I would say is yes, there are lots of reasons that folks can have malabsorption. The most common is that you end up with pancreatic insufficiency, either from the disease itself or the treatments, or from some mixture of the two. And it's fairly common actually for folks to have malabsorption, especially of fats in particular, which
Mm-hmm.
over time, right, can both lead to a hard time putting on weight because fats are so calorie dense, but also occasionally we can see some vitamin deficiencies in those settings as well, because the fat soluble vitamins go with the fat. Um, Otherwise, yes, there are other things that we see, especially in folks whose gallbladders are out, because the bile acids help with some of that fat digestion too. And then for other folks, not necessarily with pancreas tumors, when the ileocecal valve comes out in a primary surgery, that often leads to more throughput and sometimes some difficulty. So all that to say, the answer is yes, it's just complicated, but a very reasonable question to ask with the folks who have actually been tinkering with the anatomy and physiology.
Got you. Thanks, Len. Appreciate your question. Good to see your name. From Melissa, do you recommend conventional imaging at some point during the 4 cycles of PRRT rather than waiting until 3 months after completion, at which time the patient will have gone perhaps 11 or 12 months without any imaging?
It's a good question. There is tension around the answer to this question.
Lovely.
One of my good friends, Dr. Pommier, loves to say, like, just look at the end. Why would you look at the middle? And I always say, well, you look for blood loss in the middle of your surgery, don't you? Wait until you close the patient and then see what happens afterwards. So I do tend to think that in general, imaging at a similar cadence to what was done in the clinical studies, which is generally quarterly, is rational and consistent with the evidence. How often, kind of to the point from the earlier question, how often do we see the cancer progressing in the middle of the therapy? Not that often, right? Is that what I'm checking for? Yes. Am I treating my anxiety with that scan? Probably. But
Fair.
also, I think that I personally just like reducing the risk of missing things and losing track of it over time. And I do tend to think in someone whose cancer is actively progressing, it's hard for me to just close my eyes for a year. So
No.
yeah, I tend to image, but I know not everyone agrees with that. And it often depends. I will say when I really get into the weeds with folks I disagree with, oftentimes it comes down to questions of what drove the decision to start the PRRT in the first place, what the clinical context is for that specific patient, how much cancer, how aggressive it was, where we set our thresholds for when to start. And so I think it's a little bit more complicated than just yes or no, but I tend to be a yes kind of guy.
Got it. Thank you so much. Appreciate your question, Melissa. Another question from Shane. If alkaline phosphatase, I believe, levels dropped 40 points into the normal range after completing PRRT, could that mean that tumors are shrinking?
Well, as I alluded to in the early answer, if you ask could, my answer is sure. But I do think all kidding aside, um, oftentimes tumors that involve either the liver or the bone can cause some elaboration of alkaline phosphatase. And so again, one can envision normalizing it by treating the cancer and reducing that sort of liver cell or bone cell turnover. But the better answer will be the imaging, which at least if you or me, you'd be getting every quarter or so.
Gotcha. Thanks, Shane. Comment, not a question, from Deborah. I miss you so much at MD Anderson.
I miss everyone there too. I love being here, but I loved being there too.
Absolutely. Two great institutions for sure. Folks, if you just joined us or joined us very recently, this is Luncheon with the Experts, and in NCF and CCF. program. And today we're here with Dr. Dan Halperin, and we've been talking a lot about PRRT. We're going to keep the program moving forward. Let's switch gears a little bit. Lee says, is the NET test useful post-surgery in addition to scans as surveillance regimen?
So it's an interesting and complicated question, like many are in our field. What I would say is that, we have increasingly interesting data about how accurate the NET test can be. I think um, I think the reality of modern medicine, sort of like I alluded to in the introductory comments, is that there's a lot of things that look really cool, and then we have to do very specific studies around very specific questions to understand if they offer us a meaning, and our patients, I think, more importantly, a meaningful benefit or not. And I think that's a question that deserves to be studied prospectively before giving you a real answer. I know it's a little bit of a cop out, but I'd really like to understand the answer to that discrete question in a trial. That's kind of the way I tend to think about these things, though I know I'm a little rigid in that regard.
Gotcha. Thank you. Thanks, Lee. Another question from Melissa. Do you have members of your NET team at Emory who specialize in surgery, IR, imaging, and nuclear medicine for NETs?
What a really interesting question. So just yesterday, on Wednesday, we did our third um, in-person neuroendocrine tumor multidisciplinary live clinic at Emory, which I've been working to spin up for about, let's see, I've been there 9 months, so about 8.5 months. And in fact, we have a dedicated surgeon who's already sort of spinning up clinical trials in the space and is very active. Our nuclear medicine team, who already had some active radioligand trials when I arrived, and we're bringing more over the next 6 to 12 months, and some engaged interventional radiologists also in particular. And so it's interesting that the patients see the tip of the spear. Our surgeon and my APP and we would see the patients actually together in series, but then we huddled as a whole team in a room and reviewed all the films and thought through the options together for all the patients. And it's kind of exactly what we had dreamed of building for many, many years. And so I think it's fair to say, yeah, we do, and it's great.
That's awesome. Are there any gaps left in that team that you'd like to see filled soon?
So I think we have the foundation. I think that um, we're still in the realm with our gastroenterologists and endocrinologists of having senior folks who are really, really good and can tell you things because they've done it a lot, but they're not someone like me who lives and breathes specifically neuroendocrine tumors, and that's what
Right.
they want to do. So I wouldn't call it. I mean, we're filling in, but I would love to have those people too.
Next question from Joy. What do you consider growth or stability with metastatic liver tumors imaging?
Oof. It's like my entire existential question in a nutshell. Every day we ask that.
Mm.
Um, so there's no perfect answer to that question. I think we debate it all the time. And the reality is it differs depending on the person. I think both about how different the pictures are, but also how far apart they are. So that sort of pace of change. And frankly, usually, and anyone who's been with me in clinic when I'm struggling with decision knows, I put up the pictures and look at them together and say, if we can't convince ourselves in this room that this is different, then it's not. But I think it's not just about the pictures. And sometimes a change in the pictures that we might be willing to let go in someone who feels great, we might be more inclined to be more aggressive for someone who doesn't feel great. And so that mix of how's this human being doing with how do their pictures look and what's the context we put together to say what's progression. And I do mean together.
Got it. Thank you. Also, folks on YouTube, that community is growing too. Don't forget to send in your questions. I see some have just come in, and we will get to them as soon as we can. But if you're watching this show last 60 minutes, we've got more than half left. So send in those questions if you have them. Next one comes from Stephanie. Is multi-phase CT imaging the gold standard for surveillance rather than regular CTs? She has NEC Mets to the liver.
So it's an interesting question, and I'm not sure I know the precise answer, but I'll tell you why. So for conventional well-differentiated neuroendocrine tumors, I think almost everyone agrees on multiphasic imaging as being the gold standard. I think and I heard NEC range, so
Yes.
for neuroendocrine carcinomas, there's a little bit more debate. I think the classic neuroendocrine carcinoma of the lung, small cell lung cancer, nobody uses multiphasic imaging, and frankly, the pictures do look different. I'm not sure that they need it either, although I'm not a radiologist. Um, I have had some contexts where when we were looking for NECs, radiologists have advised multiphasic imaging. So I know that it's not an entirely resolved question. My sense is that, particularly for NEC, I think it's a softer, more heterogeneous recommendation.
Got it. Thank you. From Kathy. Kathy says, what is another treatment for severe carcinoid syndrome if lanreotide is not helping the symptoms?
Mhm. So, refractory carcinoid syndrome is really hard, and it's really miserable. Um, and I'm not going to pretend otherwise. I mean, people suffer a lot with carcinoid syndrome. There's a couple things that we can do when it gets complicated. Um, Depending a little bit on the symptomatology, I think about what are the maneuvers we can make, um, either if there are some somatostatin analog adjustments that can be made, things like interval or dose a little bit, but usually in folks who are suffering despite standard dose, we'll try tinkering, and occasionally it helps, but oftentimes we have to do other things. For folks who it's really being driven by diarrhea, there are those data from Telestar and Telecast with telotrestat, where it can help. You do have to give it the good old college try of a few months for the biochemistry to really work. And then I do think this is where we have some additional retrospective data, both for PRRTs. There's some data. I wouldn't give it to someone with tiny volume disease necessarily, where I wish I could save it for later. But PRRT has some data around some control, particularly diarrhea. Again, retrospective, and then the old liver-directed therapies, and even in some cases surgery. Less tumor means less hormones should mean less symptoms. It's just sort of that classic risk-benefit calculus of the various downside risks of the interventions.
Gotcha. Thank you. Thanks, Kathy, for your question. Next question from Ambi, who used to actually be a patient of yours at MD. I have an appointment with a hematologist. My lung net was removed by Dr. Antonoff, but I'm currently dealing with severe anemia. Is this a question of net cancer? I'm always having to get Venifer infusions. Is there something I can do if I'm having these absorption issues?
I will say, particularly for lung, it sounds a little unusual to me. And so what I would say is, as a class, I don't think of patients with lung neuroendocrine tumors whose tumor is out as folks who I would expect to be anemic from the tumor. That doesn't mean that it can't be related in any way, depending on the details of the individual context, but it's not a ready association. I think small bowel tumors, where things can be a little more aggressive and you can have local invasion into the bowel and some blood loss through the gut, I've seen that more commonly, and the vessels can get congested and be more predisposed to bleeding. Lung tumors can bleed into the airways, but only when they're still there, and not in the situation described. So it seems like something that might need more digging than just describing it to the tumor, but that's a 30,000-foot take.
Yeah, absolutely. Thanks, Ambi. Let me know if you have a follow-up question. One follow-up question from Lynn in reference to the question earlier about malabsorption. Is there any medication that she can take that might help with that?
So I couldn't answer a specific clinical context, but I will say Oftentimes, in situations of pancreatic insufficiency, you can supplement back the pancreatic enzymes. Often, in cases of bile acid diarrhea, in sort of folks who have their gallbladders out, and what have you, there are bile acid sequestrants that can be given. It really is tailored to the clinical situation, but you might not just have to live with it. If you can figure out what's happening, you can often offer some medicine to help.
Got it. Thanks, Lynn. Hopefully that helps. Hello to Mary from Ireland. I think this might be the first time I've seen your name, so if you are new to the show, welcome. Question from Sherry. Can surgeons tell from CT or MRI scans how much small intestine with mesenteric tumors will be removed prior to surgery?
So if there's one thing I've learned, it's to never tell a surgeon what they can or can't do. Uh, but so in my experience, what frequently happens is surgeons can usually say, based on this pattern of adenopathy, I'm expecting to ligate or cut or take this vessel, and the expected distribution in the pizza slice that Dr. Pommier talks about is sort of going to be this shape downstream, and that typically is or is not safe, right? And so the most common situation is, well, if I'm taking this ileocolic or jejunal branch versus the superior mesenteric artery itself, that often gives them a sense of whether it's an amount of bowel that will or won't be compatible with doing okay after the surgery. That being said, I've never seen them say this will mean 100 centimeters or 125 centimeters or 150 centimeters. So they can usually give a good sense, but not in the same way that they tell you after that you had X left or X removed or Y removed. It's usually more about what blood vessel they think is going to need to go and what the associated territory is and whether that tends to be safe. But especially in situations where there can be, like half the time there's multifocal primaries in the small bowel. And so sometimes they can do a little more or a little less depending on that balance of the number of tumors and where they are in the vascular territory. Sorry, it was complicated.
Oh, that's all right. Thank you. Thanks for your question, Sherry. Next question from Natalia. Does Botox or face fillers, or can they affect net tumors? And maybe even vice versa could be a question. Any knowledge about that?
Not to my knowledge. I don't know everything, but not to my knowledge.
Yeah. Thanks, Natalia. From Wasim. Wasim says, what is the best option for metastasized stage 4 reaching to the bones? It's causing a lot of pain. Sorry to hear that. So any thoughts? I mean, it's kind of a general question, but what should Wasim consider?
So we think about a couple things in those situations. Obviously, you don't want anyone living in pain with their disease, right? It often depends on the context of sort of what else is happening, where the pain is, and how complicated it is. For some of people I take care of, in my experience, they may have one spot that really bothers them, and I often say you can just spot weld or zap that spot with external radiation, and you can make someone feel better pretty quickly. As long as you actually have it right that that's the spot that's causing the problem. And I think sometimes you end up in tricky situations of, are you quite sure or are you not? And then it gets really difficult. The other one, if people have more diffuse discomfort in their bones, which is absolutely awful, is if there are somatostatin receptors, PRRT can cool that off. Sometimes, basically give them all radiation while giving some disease control. And then I think for other folks, depending on the details, other cytotoxic therapies can be helpful, right? So for pancreas or thymus, temozolomide sometimes can actually cool that off pretty nicely. So it depends, but it really shouldn't be something someone has to live with.
Got it. Thank you. Okay, we got some questions coming in from our YouTube community now. Exciting to see. First one from Paul, also former patient MDA. Just started 10 milligrams of Finitor, and initial scans showed stability and no new growth. Great news, Paul. Is toxicity or tumor growth more likely to force a change in this treatment?
Ooh. I mean, Shoot, I should probably go back and reread the clinical trial and see how many people dropped out for toxicity. But usually, when toxicity outweighs progression as the reason for discontinuation, that drug does not survive. So, as a blanket answer, the most likely thing is eventual growth. The other thing, though, that I will point out, again, a conversation I just had yesterday. Um, for some folks, the dose out of the box isn't the right dose for your body, right? And um, people whose bodies need a lower dose, like that's their metabolism. These things are not perfect. Um, the key is if you're on it for a long time because it's comfortable for you to take, that's better than toughing it out for 6 months and needing to quit. And I think there's plenty of people who will attest that it was 5 or 7.5 that was right for them, but they got good control out of it as a result, and they didn't have to suffer in the process.
Yeah. Thanks, Paul. From Sarah, at the end of the second round of PRRT with monthly lanreotide for a PNET with liver mets, Creon is super helpful, but the diarrhea remains a daily challenge. This is certainly a common question. Thoughts about any other things to try during this time?
I'm sorry, I may need to look at it for.
That's
Okay,
okay.
I
From
found it.
Sarah? Yeah.
Yep. I'm sorry. Give me just 1 sec.
No worries.
That's it. Yeah. I mean, I think oftentimes, truthfully, when I get into the complexities and the minutia of diarrhea, that takes a little while to sort out.
Yeah.
And a lot of the time, what I've seen is I was really fortunate. We talked about the doctors on a neuroendocrine team. We didn't talk about all the other important members of the neuroendocrine team, and I swear by my dietitian. So both Stephanie, the dietitian I worked with at MD Anderson for 10 years, was spectacular, and Whitney, my dietitian here, is great. And oftentimes when we have to drill on those precise relationships between foods and diarrhea and creon and some of the other indicators of some of the other reasons that people end up feeling ill, and then how we titrate things in response, oftentimes we need to lean on the whole team. So I wouldn't even pretend actually to give an answer to a question that complicated off the cuff. It's tough.
Yeah.
It's tough.
I'm glad you mentioned that, though, because I think those positions are also very important as part of multidisciplinary teams. So I'm glad to hear that you prioritize those positions as well. I think that's a really cool part of how we tend to approach this, is really getting these multiple perspectives because it's such a unique and complex disease. But thank you for your question. Here's a great question, which is, I know the answer will be, it depends, perhaps on your unique case. However, it does prompt a good discussion to have. I love this question from Becky. Is it safe to lead a normal life? I'm assuming with a net. For example, theme parks, massage, gym, running, etc. Or is there anything that should be stopped?
Yeah, this is one of my favorite questions, and I'm gonna fight back, Rain. So my answer is, please live a normal life.
I love it.
Right? So the answer I always give is that the whole purpose of everything we are doing inside the four walls of the clinic is to help our patients live a normal life.
Yeah.
Right? So yes, are there sometimes you're radioactive, that you have some constraints? Yes, but in general, I always push people to get really, this is true not just in the neuroendocrine universe, but in sort of all of medicine. Let's get really clear and really specific about that, right? What is the thing that we think prevents us from living a normal life? And is that thing real or imagined? Oftentimes we will hear things like, well, immunosuppression, right? But the vast majority of the therapies in the tumor itself don't demonstrate any immunosuppression, right? So we have to and sometimes they do, and we can see that in the laboratory values, and we can talk about it, but we should get really, really clear about what we think the barrier could be and whether it's real or imagined, because we want you to live your life, please.
Love that answer so much. And love that question, Becky. Appreciate you. Thank you for that. Next question from Jim. Great show as usual. My favorite topic. Lutathera was recently presented as an option to start for a very small pet spot. I read much about the newer alpha versus beta variations, and I was told alpha wasn't offered at X location, but why not try beta? And beta, if not good results, you may be a candidate for A. The question from Jim is, why not seek out alpha first?
Sure. And you're more than welcome to. But here's the catch. So there is currently no FDA approved or by association proven alpha therapy for neuroendocrine tumors, period. So in the same vein of we make progress by doing science and measuring the result and seeing the benefit and risk to people and being able to describe those to people to make decisions, we don't have that today. There's an ongoing alpha randomized trial in the second line setting. That's action one. So people who do receive beta, lutetium, PRRT, and then have some control and subsequent progression, they can be randomized to basically the alpha therapy now or the alpha therapy after some alternative fails them. That's an active trial now. So if the results show that it helps, right, then it would be an available therapy on the market. We've seen phase 2 data with the lead agent that's not, to my knowledge, yet in a randomized trial that exists to talk about. But those data were in patients who hadn't received PRRT before. So at least some of the John Strasberg and group data that I've seen. So all I would say is that remains an investigational therapy, and we always encourage patients to engage with investigators and ask whether clinical trials are right for them. That's how we all learn and make progress together. But alpha therapy is not yet standard. I say yet as if I know the answer. We don't know the answer yet, but it's not standard today.
Got it. Thanks, Jim. Good to see you up here. Nikki says, what are the next steps after finding out somatostatins are high? I've had diarrhea for 10 months now, and it is affecting my life badly. Sorry to hear that, Nikki.
Well, so it's interesting. I mean, somatostatin itself is a relatively uncommon secretory product. It exists. It's in the literature, but it's rare. So believe it or not, the classical teaching is that if that's a problem, you could try a somatostatin analog. I don't know if I believe that, but that's technically what we always say. But the question I would actually ask is whether potentially the diarrhea is actually from that same pancreatic insufficiency that we see with somatostatin analogs. And again, working with your team and your dietitian and thinking through the exact cause and sort of manifestation, as it turns out, not all diarrhea is the same. Thinking about whether those same strategies, whether pancreatic enzymes are appropriate, may be worth thinking about. But high somatostatin levels is quite uncommon. Quite uncommon.
Got it. Thank you. And a follow-up question from Nikki. Can an MRI with contrast see any net, no matter how small?
I wish. The reality is that no test is perfect. We have yet to invent the perfect test that always sees everything no matter what. I think a lot of times the way I tend to think about these tests is how good are they at telling us about something that we should be concerned about, right? And so, yes, one tumor cell would escape an MRI, right? Our resolution is not that fine, but one tumor cell won't hurt someone anytime soon. And the notion of doing serial imaging over time is that if it should crop up and cause a problem, you will see it eventually. And I have to combine that with the knowledge from multiple clinical trials that we have yet to see a benefit to people for starting something sooner versus later, right? So we often sort of turn to even the original somatostatin analog trials, huge benefit in terms of cancer control. but everyone eventually did just as well as long as they got the somatostatin analog. It didn't matter whether they started on it or started on placebo and got it later, you catch up in the end. So, it's a little bit of an existential question, but if that cancer cell is falling in the woods and there's no technology that can see it, treating it when you can makes you no worse off.
Got it. Thank you. Another question from Wasim. What is the role of vitamin C therapies or alpha lipoic acid drips in controlling neuroendocrine cancers in particular, which are known to be slow growth? Any thoughts on those?
Only that in my years of, seeing patients and studying the literature and doing this, I've not seen evidence that those help patients with symptom or tumor control in a convincing way. So I would simply ask whoever offers you those things to show you the randomized clinical trial that says that it will help you, and describe for you the risks and benefits from that trial, which typically would be associated with a drug label from FDA, typically. There are certain circumstances in which that's not true, but I would usually just ask for the information and the data, and you have a right to see what has led to the recommendation and understand it yourself.
Absolutely. And folks, I mean that particular question might be a good example, but I see a couple of examples where you all are commenting to other people's questions. That's exactly what I was talking about at the beginning of the show. Like oftentimes it's the shared experiences that can be helpful too, like from Brian and Matt chiming in to some of the questions. I love to see that, so appreciate you all. Next question comes from our friend from South Africa, Ursula. Hey, Ursula. I've had 9 rounds of PRRT. Obviously, we don't have that available yet in the States. My first in 2021 to mid 22, then growth 7th round in September 24, 8th in January 25. The last 3 I battled terribly with fatigue, which took me 6 rounds plus to recover. My liver enzymes are very high, gamma GT 2200. Could this be that tumors can become aggressive so quickly after nuclear PRRT treatment? Did you follow?
Well, if the question is could, the answer is sure. Um,
Yeah, there's a theme today.
I mean, I think there are lots of things that can happen when we give all those doses. I think the data that we've seen from Europe with PRRT retreatment and retreatment, which, if memory serves, was generally more like 8 doses rather than 9 per se, was that in folks who continue to do well, they generally continue to do well. So no sort of alarming significant rise in either in toxicity. I think as we get these things are all, I think we should be transparent. All of our therapies are poison in one way or another, and you give a lot of it and you can start to see on target or off target effects. Yes, the cancer can become resistant and grow out, but yes, the therapy itself could also do damage to things, including the liver or what have you.
Next question. Folks, we got just more than 10 minutes left, so we're going to keep moving forward and get to as many of these as we can. Ronald says, I have been taking 2 milligrams times 2 of a copper supplement for a year, yet my copper level is still low. Is this a common problem? And if so, anything else we should advise Ronald to do or think about?
I am not ashamed to admit I don't know the first thing about copper anymore. So what I would say is that that's not a common problem that I end up encountering, and I've forgotten anything I ever knew about how to deal with copper deficiency.
Gotcha. Thanks, Ronald. Let us know if you have any other questions. Shane, follow up to a previous question. After 2 PRRT, his mom's specialist said that there was pseudoprogression, millimeters of change, and new subcentimeter lesions apparent, attributing this to pseudoprogression or growth happening in the month between starting PRRT and the previous MRI. SPECT scan shows stable disease. Question is, what are your thoughts on pseudoprogression on patients who have high uptake on gallium SPECT?
Yeah. I mean, so pseudoprogression is a really interesting concept. And actually, I will say that question so beautifully illustrates the question I often ask folks who believe they're describing pseudoprogression, which is, do we truly believe that it happened while the person was receiving the PRRT, or did it happen in the time before the prior scan and the start of PRRT, which is probably a tree falling in the woods that none of us get to witness and really know. I think small changes on imaging are not uncommon regardless of the therapy, and I'm not even sure I would classify that as meaningful pseudoprogression. I would just say sometimes we see millimetric changes, and they're not always significant, and time tells us that. This is, by the way, the exact argument for why people like me who get scans in the middle are wrong, is sometimes you see things that turn out not to matter. But at least I can acknowledge the tension around it.
Yeah, that's fair. Tension causes progress, though, right, and growth. Typically, sometimes, hopefully. Ray says, I'm a patient, MD Anderson. And here, there's also a theme, and I'm part of the NETTER-2 trial. Dr. Yao doesn't think a second round of PRRT is beneficial, but I was anxious to do another round as it's given me a relatively normal life for the past 2.5 years. What are your thoughts on this?
So here's what I would say. I've worked more closely with Dr. Yao than with any other person
Right.
on the planet, and we have bounced tough cases off of each other for over 10 years. And the daylight between us is usually slim. So what that would say to me is that there's probably something in that story that I don't understand. Typically, when folks get a long period of control with PRRT, we do think about doing more. But what it says to me is, I'll bet there's some subtlety that would make me say that wasn't a good idea that I don't know, right? Because he really is genuinely sort of one of the smartest, most thoughtful folks on the planet. You can't always tell. I've always told him to be one of those delightfully opaque human beings on the planet, and it's one of the characteristics I really enjoy about him. But he actually, it's there. So I would encourage you to ask directly, but he usually turns out to be right, is my experience.
Fair enough. Yeah, fair enough. Kind of a follow-up question, or backing up and laying a little bit of foundation for folks. There's a question about just defining what pseudoprogression means, coming from Stacy. Oh, that's it. Just, can you define pseudoprogression? Like, let's
Sure.
establish
All
what that
right.
is for someone that's a new term for.
So pseudoprogression refers to the notion that there can be some change on the image that appears to be growth, but is not actually representing the cancer getting worse, and often will get better later. The kind of classic examples are some immunotherapy situations and some radiotherapy, usually external beam, where people describe some sort of swelling, inflammatory response that then later will recede. As I alluded to in the discussion, I'm not 100% confident that that is a real thing that definitely happens with PRRT,
Okay.
in part because of some of the way the data have been generated. But at the same time, we frequently see millimeters of change in either direction that turn out to kind of just be noise rather than signal.
Got it. Next question from Jackie. Jackie says, I was diagnosed with carcinoid tumor in the small intestine at the ileum. Surgery done, tumor removed, and the ileocecal valve. This was in 2011. Was going to Oshers. Oh, okay, for several years for follow-ups. Haven't been back since 2017. Had a CT scan in 2022. Was told I could come back in 5 or 10 years. This is also a common question of, like, for some people, I'm not trying to put words in Jackie's mouth. The question is, like, what do you think? But often when those follow-ups, the length in between starts to grow, there's like, are you sure about that? So that, I think that's where Jackie's coming from.
Well, and it's also an area of some tension and evolution in the
Yeah,
consensus over time, right?
totally.
So I think where the current consensus sits, at least to my knowledge, is that, we typically do follow people, again, sort of assuming classic, grade 1 small bowel neuroendocrine tumor that comes out entirely. Um, and we're talking about local or local regional disease. We typically do imaging every year or two for 10 years with an asterisk. And that asterisk is in the guidelines that basically says young folks who are doing great, we can always offer them more imaging at the same cadence for longer, because there are some signals that late recurrences can happen with really indolent disease. Um, I think, that ongoing balance of making sure that we are minimizing radiation and anxiety and sort of the harm that we can do as a medical community with more testing. Oh, is it me? Is my sound gone?
I hear you. I hear you fine. Folks, other than Eileen, let us know if you can hear everything okay. Just a yes if you can. It sounds pretty good on my end. So Eileen, also check your volume on your computer. But let's keep going there, Dr. Halperin.
So all I was trying to say was, it's a soft boundary at 10 years, just trying to balance the risks and benefits for the individual. So not crazy. They're probably reading the guidelines perfectly well when they say you don't necessarily need any more. But it is a conversation one can have. Okay, thanks. Sound is going.
Great, lovely. Speaking of tension, to use your words, another topic that is often debated, discussed on the show and out in the net world is sequencing. I wonder what your thoughts are in terms of how you approach sequencing. If it varies from patient to patient, if there's a typical sequence that you would prefer to see. Just know that's a topic that we often get asked about, and there's a lot of feelings about and activity going on studying that right now, I think.
Yeah, I think it is a really good question. This will surprise precisely no one. I am in the camp that believes that it's mathematically unknowable what the
Yeah.
perfect sequence is. Um, that said, I think that usually, I mean, the things that you're balancing, right? What is the pace of disease that you're seeing? What is the volume of disease that you're seeing? Who is the human being you're taking care of? How do the different options fit into their life? Um, do I generally have a preference for doing less rather than more and doing less harm rather than more whenever I can get away with it? I do. Um, so that tends to mean leaning on what I tend to think of as lower intensity therapies that tend to have fewer long-term risks earlier on. Um, unless the cancer tells us that that's not okay, right? Or sometimes, when people come in with clear preferences and reasons for wanting one therapy versus another, we'll say if we don't think it's reasonable, but if it is, right, we try to abide by those preferences too.
Got it. Thank you. Last question for today. I mentioned earlier we were talking about multidisciplinary teams, tumor boards, et cetera, and if there are any gaps, on your team that you'd like to see filled. Similar question, but in terms of, we have seen this flurry of activity and trials in the past few years. Where would you, if we look out to maybe 5 years in the future, where would you like to see more time, resources, research being done? Like, where are some of the gaps that you would like to see addressed in the next 5 years or so?
So I think there's, maybe separate this into two kind of
Okay.
fundamentally different buckets.
Okay.
Um, one of them that I think is, sort of the wide open bucket, if you will, is, to this day, we do not have a randomized trial to describe the risks and benefits of local interventions for patients.
Hmm.
Um, there was the randomized RETNet study, but it really didn't fundamentally ask whether the local therapy was good. It asked which one was better, right?
Yeah.
Sort of reminiscent of the bevacizumab interferon trial, SWOG 518. It didn't actually tell you whether either was good. It just asked whether one was better. And so I think that trying to prospectively define the role of those therapies so we can counsel our patients appropriately on when they can be deployed and what the benefits and risks will be, I think is kind of a fundamental open white space in our field, that we owe our patients to address. The other one I think is kind of all the way in the opposite direction, which is um, I'm not yet convinced that the, if you will, ill-informed application of early immunotherapy really means that there is no immune environment to take advantage of in for our patients. And I think there's a bit of a, we did a few trials and immunotherapy is dead sense. But I think it's because we weren't smart enough to know what the right tools were. And I'm not saying for sure that we are today, although we're making some progress. But I think we have to be careful about throwing out sort of an entire class that has transformed the rest of oncology simply because, you know, the hammer that we had wasn't finding the right nail to benefit our patients. So that probably is a little harder because the space is more congested, and I think there's less enthusiasm given the prior studies, of which we were a part of several. But I think those are things that I'm really interested to see some more resolution around over the next 5 to 10 years. Good
Love it.
question.
Yeah, great answer and great episode today. That is our show. It is the top of the hour. Dr. Halperin, thank you so much for being back.
Yeah, thanks for having me. It's been really fun. Great questions, everyone.
Absolutely agree. And thanks as always to you folks at home. I hope this program helped answer some of your questions. One more time, I want to send all my love to the Warner family. And some of you already know we had put a post on Facebook. And if you look at the comments or the shares on that post, you will see the impact that I mentioned that Dr. Warner had. So many people saying I would not be here today if it weren't for Dr. Warner. So all my love to the Warner family during this time. And folks, that is our show for today. Finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next time on Luncheon with the Experts. We will not be here July 3rd because of the holiday on the 4th, so we will be back on July 10th. Stay healthy.